to spend 30 minutes here and try and look at the emergency recognition and initial ICU management of each of these endocrine crises. We're going to begin with the thyroid emergency, starting with thyroid storm, which is really just the extreme manifestation of thyrotoxicosis. Most of the time that's caused by hyperthyroidism, and the most common cause of hyperthyroidism is Graves' disease. Vying for second place are the toxic uni and multinodular goiters and thyroiditis. And most of the other etiologies shown on this list are pretty rare in their own right, almost unheard of for causing thyroid storm. One exception is at the bottom there, and that's when a patient takes, say, an intentional overdose of pharmaceutical thyroxine. That indeed has caused thyroid storm, including fatal cases reported in the literature. Now, a common theme that you'll see running through all of these endocrine emergencies is the concept of a precipitating factor. The patient has their underlying endocrine illness. Maybe it's never been diagnosed. Maybe it's under treatment. Things are under control. It's otherwise compensated. But some physiologic stress comes along, maybe an operation, injury, childbirth, some intercurrent illness, but something comes to tip them over the edge, and they go from a compensated state to one of decompensated endocrine illness, resulting in an emergency, such as in this case, thyroid storm. Any of the symptoms and signs of thyrotoxicosis can occur in a patient in storm, but to qualify for storm, your patient's going to need at least one of two symptom complexes, and that is either some significant derangement in their central nervous system function, like encephalopathy or psychosis, altered mental status, or some significant cardiovascular abnormality. This is most of the time a tachydysrhythmia, the most common being atrial fibrillation with a rapid ventricular response. It's often very difficult to control. They can also get hypertension with a widened pulse pressure, a high output form of congestive heart failure that you can think of as a potentially reversible form of cardiomyopathy. Pretibial myxedema, that refers to a non-tender, non-pitting, brawny swelling of the shins. It's seen only in Graves' disease and then only in about 2% of cases, and it's due to mucopolysaccharide infiltration in that area of the extremities. The same substance that's responsible for the ocular manifestations of Graves' disease, such as the thyroid stare shown there, which can progress to cause ophthalmoplegias, corneal lesions, and in the worst cases, impaired visual acuity. I have here some nonspecific laboratory findings, elevations in calcium, glucose, and liver function tests, but the money really is with the thyroid function tests. And for, 95% of the cases in the ICU, the only two tests that you're going to need here are the free T4 level, which is now widely available, and the sensitive thyrotropin or TSH level. Used to be that the TSH assay was insensitive in the normal and low range, and therefore could only be used to diagnose hypothyroidism. But nowadays, I think we're on the fourth generation of TSH assays, and they're capable of measuring to very low levels, and we can use it to diagnose both hypo and hyperthyroidism. Now, the treatment of thyroid storm is five-pronged, and we're going to take them one by one. The first thing to do is to stop hormone synthesis. Now, this, could be done by surgical removal of the thyroid gland or radioactive iodine ablation therapy, but those modalities have no role in the acute management of thyroid storm. Instead, we're going to have to rely on one of these two thionamide drugs, propylthiouracil or methimazole, and they basically block the synthetic enzymes in the thyroid and prevent hormone production. Next, we're going to blunt end organ action of the hormones. These thyroid hormones are not adrenergic receptor agonists, but they do influence the adrenergic system, probably in large part by increasing receptor density at the end organ tissue level. And the agent of choice here is the beta blocker propranolol. number one, because we have most experience with it, but also because it's a non-selective beta blocker. It crosses the blood-brain barrier and probably has some other potential favorable advantages compared to other beta blockers. For your patient who may have a strong relative contraindication to beta blockers, you can consider the use of esmolol, that ultra-short-acting parenteral agent. If you get into trouble from, say, bronchospasm, you can turn off the infusion, and that effect will dissipate in a matter of minutes. I find that patients with AFib and a rapid ventricular response often are difficult to control, even with high doses of propranolol, and may need supplemental diltiazem. And for the patient who can't tolerate those drugs, there's some older agents, although less information available in terms of an evidence base for their use. Now, even though you can stop thyroid production with, say, propylthiouracil, remember that the thyroid gland serves not only as a factory to manufacture these thyroid hormones, but it also serves as a repository to store them. Even if you completely stop synthesis, the gland's going to go on to release the stored hormone for a period of days, weeks, or even months. But you can stop that, and the usual way of doing that is by giving some form of iodine. The traditional agent is Lugol's strong iodine solution. You give this orally or down the NG tube. If you have some of these oral cholecystographic agents laying around the hospital, this is Orografen and Telepaque, then you can give those. They'll do nicely, but they're in short supply of late. If your patient's NPO, you can give sodium iodide intravenously. If for your patient that is allergic to iodine, there's some other agents that also have this effect. The one at the bottom of the list has been used. Remember, it has a narrow therapeutic index, so we normally don't use that, but could be used in this carefully in the setting of iodine allergy. And next, remember that although the thyroid gland produces two hormones, T4 thyroxine and T3 triiodothyronine, it produces mostly T4. The majority of T3, which is the more active of the two hormones, is produced at the level of the peripheral tissues by this deiodination reaction catalyzed by a series of isoforms of 5' deiodinase. And there are several drugs that are known to be able to inhibit that enzyme and decrease this peripheral production of T3. If you're giving propranolol already, as we've seen, then this is already taken care of, and several other agents there that can do the same thing. So these are the four specific treatments for thyroid storm: stopping hormone synthesis, stopping hormone release, blocking peripheral conversion, as we just seen, and using chiefly beta blockers to blunt the end organ effects. The last prong of therapy is supportive care. All of these patients need to be treated in an intensive care unit. Remember to search for and treat any identifiable precipitating factor. A lot of these patients will be hyperthermic, and you'll need cooling measures. Probably shouldn't use aspirin for that. Salicylates are known to be able to displace thyroid hormones from their carrier proteins in the plasma. Although, having said that, I wouldn't hesitate to treat, say, concomitant acute coronary syndrome with aspirin if you have a good reason for it, but not for general antipyretic use. Now, if thyroid storm is the extreme manifestation of hyperthyroidism, then I think the analogy for hypothyroidism would be myxedema coma. Most of these cases are going to be due either to a burned-out case of thyroiditis, or they're going to be iatrogenic. That's a patient who had their gland surgically removed or ablated and placed on lifelong thyroid replacement treatment, but for whatever reason stopped taking their thyroid supplement and eventually developed hypothyroidism. Amiodarone, alpha interferon, lithium are some drugs that can induce this. And the last one on the list there is sometimes called endemic goiter. It is mainly of historical interest in the United States. There are a number of places in the world where there's not much iodine in the soil. This is one of them around the Great Lakes region of North America, and that's due to glacial runoff. But since we've added iodine to most formulations of table salt, that's thankfully mostly a thing of the past. Now, any of the subjective symptoms and physical findings of hypothyroidism can be seen in myxedema coma too. Plus, you can almost always recognize this just by walking into the room and looking at the patient. You've got, of course, facial features, the the unmanageable hair, the expressionless look, the periorbital puffiness. And if you don't recognize it just by eyeballing the patient, you have a second chance if you try and get some history out of them. Because if they're even just a little bit awake, I find that there's often this characteristic delay between the time you finish asking them a question and the time they answer you. And I swear sometimes it can be as long as a minute, which doesn't sound like much, but a minute's a long time when you're waiting for an answer. And then when they do answer you, it's in this hoarse, frog-like voice, and it kind of startles you, because you're like walking out of the room and all of a sudden they answer your question from 5 minutes ago. Remember, the deep tendon reflexes can be depressed, hyporeflexia with the delayed relaxation phase if they have any reflex left. Also, the precipitating factors are a key point here as well. The one that's impressed me on this list the most is this one. I remember a couple of striking cases, patients admitted to the hospital, not to the ICU, admitted to the regular floor. They were there for some non-endocrine problem. One had prior diagnosed hypothyroidism, another had no history, and they got a routine sleeper prescribed for their admitting orders. First night, got their sleeping pill. The next morning on routine vital sign checks, neither one were responsive. Both wound up coming to the ICU and had precipitated mixed edema coma. So these patients are exquisitely sensitive to drugs in general, and in particular to sedative, hypnotic, and narcotic medicines. On your right are some of the specific laboratory tests for hypothyroidism, and on your left, some nonspecific tests. All of these patients have a blunted respiratory response to both hypoxemia and hypercapnia. If they're not in respiratory failure when you get called to see them, then they have a high chance that that's going to happen sometime before they get better, even with treatment. So you have a low threshold for giving them a positive pressure ventilation or intubation. The key laboratory test here for confirming the diagnosis, however, is the TSH assay. Doesn't matter whether that's one of the old version assays or the new versions. It'll be quite elevated, always in at least the double digits. Occasionally you'll see them in the triple digits, and that will clinch the diagnosis. I have a question here for you. It says, which of the following patterns can be seen in the euthyroid 6 syndrome? If we could start the clock, please. So is it decreased T4 and T3, normal or increased TSH? Is it a decreased TSH level? We're waiting for the clock there to go. Is it an increased reverse T3? Or is it the last choice, all of the above? We'll see what we get. Very good. So all of the above. So this is the euthyroid 6 syndrome. It's a poorly understood syndrome. The question is what is it? How do you recognize it? What's it mean? And I've kind of illustrated this here schematically. On the y-axis here, we've got hormone level, and the normal range is in this shaded region. And on the x-axis, we have severity of illness. You could also think of the x-axis here as time, if you start out with the patient being healthy at this end, and then getting sick and progressively getting worse and worse. So one of the first things that happens is the free T3 level becomes low. Whenever I see anybody in the ICU ordering this level, I kind of tell them probably isn't necessary because it's going to come back low. This is 99% of people in the ICU. It's going to be low, so it makes it pretty much a worthless test in that setting. If it comes back and it's not low, then you probably have a patient there that doesn't belong in the ICU. The next thing that happens is the free T4 level tends to get a little bump here and go up. And if the patients really get sick, really become, near death's door, then pretty much everything's going to be low. The thing I didn't show on here is the TSH level. It's the one hormone that tends to be the stablest. So if you're going to try and rely on any of them, that's the one that will give you the most useful information, although it too can be low and in some cases even a little bit high with this euthyroid 6 syndrome. These patients do not have any stigmata of thyroid disease, any evidence of thyroid disease, yet their laboratory tests here are off. And the reason for that isn't really clear. It's poorly understood. The faint one there at the top in red is the RT3 or reverse T3 level that's elevated. And reverse T3 is simply a geometric isomer rearrangement of the iodine atoms on the triiodothyronine molecule, as you can see there. This has no known biological activity. It's not known why we make it or why it's high in this situation. It could be used as a clue that this is what's going on with your patient, except that the test is not very widely available, so you have to send it out, and by the time you get the result back, you'll probably have figured it out anyway. The treatment here is, first, the patient needs to be in a unit. As I mentioned, there's a high likelihood of them having to have respiratory support. If they really are in a coma, then you start out with dextrose as a kind of a routine or a point-of-care testing to rule out hypoglycemia. They're often hypothermic. You want to use not active rewarming because that can precipitate hypotension, but simple passive rewarming. And the key to therapy there is to give them the hormone that they're missing. You can do that just using T4 alone, levothyroxine. The dose is 300 to 500 micrograms is the current recommendation, and then a daily dose of around 100 micrograms a day. Most authorities recommend that you start out at least by concomitantly giving them hydrocortisone, and the rationale for that is that endocrine disorders tend to run together. So some of these patients will also have adrenal insufficiency. If you rev up their metabolism with this big dose of thyroxine, that could precipitate acute adrenal crisis. So cover them with hydrocortisone, or alternatively, you could do the rapid cosyntropin test, which we'll see in a couple of minutes here. But first, let's look at hypoglycemia. It has a long differential. I like to divide it in half right off the bat here into the fasting and the fed or postprandial etiologies. In the ICU, if your patient's hypoglycemic, we don't need to embark on a big detailed workup for all these send-out tests for esoteric, autoimmune, and tumor-related causes, because most of the time it's due to insulin now with relatively tight glycemic control, and other things here that are very common in the ICU: organ failure, sepsis, drugs, and so forth. So only when it's recurrent or persistent do we have to worry about some of these less frequently seen disorders. On the Fed side, this is the common one that everybody thinks about. Most endocrinologists don't believe it exists. The one that I'll comment in particular on is the discontinuation of TPN. So you'll see this occasionally. Some patients will get away with it, but some people on TPN, it's a big glucose load. It revs up their pancreas to produce lots of insulin. If they can't make the insulin, then you're giving it to them. And then occasionally their central line will become dysfunctional or fall out, and it stops their TPN abruptly. The dextrose that they got gets metabolized. The insulin is still there. It's still having an effect, and they're kind of a setup for hypoglycemia. So if something happens to the central line in those cases, start a peripheral infusion of D5 or D10 while you're waiting to get a new central line in place, or at least check their blood sugar every hour to make sure that doesn't occur. In yellow here on your left are the neuroglycopenic manifestations of hypoglycemia. They all occur when you cross a fairly sharp boundary of around 35 to 40 milligrams per deciliter. And on your right are the hyperadrenergic manifestations, which also occur with absolute hypoglycemia, but at least for some patients it seems that they can also occur if you simply drop the blood sugar by a large amount, even if you're not anywhere near the hypoglycemic range. Some people with diabetes use that to their advantage as a cue that their blood sugar is falling, although most diabetics kind of burn out that autonomic response after a couple of decades or so. Now, these are the ones that really cause concern and make this a real emergency. In the worst cases, if the blood sugar is low enough or if the hypoglycemia is prolonged enough, you can get seizures or coma, and there are even cases on record of people being left with permanent neurologic deficits. The worst case being a persistent vegetative state. So you need to treat this right away, and every medical student knows that the treatment in a hospitalized patient is to give an intravenous injection of concentrated dextrose. That's simple enough. If the patient doesn't have an IV, you can give an IM injection of glucagon. That's usually handy on most crash carts, and that'll tide you over till you get the IV in place. Where I find that my medical students falter is they think they're done at that point once they give the dextrose, but there's really two other important emergency aspects to this treatment. The second one is to give an intravenous infusion of dextrose. And that's because whatever caused the hypoglycemia in the first place, it's probably still there. And as soon as that dextrose bolus you gave is metabolized in an hour or so, the hypoglycemia is going to recur. And I'm no genius. I learned this a long time ago the hard way. You get called for hypoglycemia, cure the problem, go away, you get called back. Another hypoglycemia, same patient. And after that happens 2 or 3 times, you finally catch on. And then you also need to institute some kind of more vigilant monitoring here, because this is kind of a guess at how much to give, and it can still recur. So step up the degree of monitoring, say on an hourly basis, at least until you can prove glycemic stability. If they're already on a D5 infusion, they obviously need more, so you can increase the rate or change to D10 or otherwise make sure they're getting more dextrose. These two hyperglycemic disorders sometimes cause some difficulty in terms of classification. On the one hand, we've got diabetic ketoacidosis. The classic patient would be a young adult with juvenile onset insulin-dependent diabetes, presents with a blood sugar of 500 or so, plenty of ketones in the blood or urine, moderate to severe metabolic acidosis. Over here, you've got the hyperosmolar non-ketotic syndrome. That's classically an elderly patient that presents in a coma. They got a history of type 2 diabetes or maybe no history of diabetes at all. Their blood sugar is 1,000 or better. They've got no ketones, as this nickname implies, and no signs of metabolic acidosis. But what happens when you have a patient that kind of has some features of both? Blood sugar 900, trace ketones, maybe a little bit of metabolic acidosis. Some people call this overlap syndrome. You can also look at it as kind of a spectrum here, and some people are in between. I don't think it's worthwhile getting hung up on how to classify them, just kind of recognize that it is a spectrum and understand the pathophysiologic difference, and that is that patients over on this end of the spectrum have no insulin. With no insulin, you'll get diabetic ketoacidosis. Everybody will. If you've got just a little bit of insulin, it prevents ketoacidosis from forming, but it may not be enough to prevent hyperglycemia. And that's how these patients wind up with very high blood sugars and in some cases no evidence of ketoacidosis. Precipitating factors occur in both. Leading the list depends on the series you look at. It's typically either in DKA, either infection or noncompliance. Probably depends on how good of compliance you have in your local population. Similar over here with the HONK, but there's some important differences. Remember, some of these patients don't have diabetes, or at least hasn't been diagnosed yet, or they make do on oral agents where compliance is easier, so that makes noncompliance lower. And the miscellaneous percentages here look about the same, but over here they tend to be things like heart attacks and strokes because this is an older crowd and more prone to those illnesses associated with aging. The manifestations are pretty much similar in both extremes with some notable differences. If you really don't have ketoacidosis, then there will be no acetone odor detectable on the breath. If you don't have metabolic acidosis, there will be no Kussmaul respiratory pattern, but otherwise any of these other things can obtain in either illness. The CNS changes are notably different too. Both they tend to look the same initially, but DKA patients, they don't want to talk to you. They lay there like they're in a coma, but you can wake them up. If you pester them enough, they'll answer some questions for you, mostly telling you to leave them alone, whereas these patients tend to really have a high degree of encephalopathy and sometimes frank coma. Deficits here in DKA average in adults around 6 or 7 liters, so that needs attention. And as Dr. Dellinger went through yesterday, also some electrolyte deficits. Even though the total body potassium is depleted in patients with DKA, they present hyperkalemic, not because of the acidemia. That happens with mineral acidoses, but not with organic acidoses like in DKA. It's rather because of the lack of insulin. As soon as you give them the insulin, it shifts the K into the cells, and then their total body deficit will manifest with first normalization and then an abnormally low potassium, so you need to start treating that right away. Monsieur Rodin here is telling us it's time for another question. We could bring up our other question. So it says, which IV fluid is best for a patient with HONK coma? blood pressure 80/46, sodium 162, and a whoppingly high glucose there at 1,730. Please start the clock. Will it be number 1, normal saline, number 2, D5LR, number 3, third normal saline, number 4, D5W, or half normal saline? Our answer by democracy there is number 1, normal saline, so that's very good. That's the correct answer. The thing here is that we have two competing pathophysiologic derangements. On the one hand, this patient's in a coma because of the hyperosmolar state, and hypotonic fluid would help to treat that, to correct the hyperosmolar condition. On the other hand, this patient is in hypovolemic shock. That's part of these hyperglycemic syndromes, and that intravascular volume depletion would be better treated with isotonic crystalloid rather than hypotonic fluids. Well, the priority scale is telling us that the greater threat to life here is the hypotension. That's a reflection of decreased perfusion to vital organs, and we need to fix that first. Also, the hyperosmolar coma, there may be a problem there if we try and treat that too rapidly. There's some evidence to suggest that could have deleterious effects. So start out with normal saline. After you get the hypovolemia under control, then you can concentrate more on fixing the hyperosmolar state. I won't belabor the treatment. Also, Dr. Dellinger covered this yesterday. Including bicarbonate. No evidence that sodium bicarbonate is necessary to treat this syndrome, although it often still is in severe acidemia. Don't forget to look for and treat any precipitating underlying cause. On your left is a portrait of Thomas Addison that hangs in the Guy's Hospital Museum in London. On your right is an autopsy drawing that he made and published in his 1855 treatise entitled On Diseases of the Suprarenal Capsules. And it shows the caseous lesions of tuberculosis affecting the adrenal glands of his index patient who died from adrenal failure. Now, in Addison's day, the most common cause was tuberculosis, but today, at least for primary adrenal failure, it is the idiopathic variety and chronic adrenal insufficiency, and that's now known to be due to autoimmune mechanisms. Also on the list there in yellow, we have a variety of infectious diseases. That includes the classic Waterhouse-Friderichsen reaction from meningococcemia and pseudomonal sepsis. In the HIV era here, we can add some opportunistic infections that can affect the adrenal glands like cytomegalovirus. Over here in green, we have the secondary causes that's due to hypothalamic or pituitary injury or disease. And the most common cause overall is the last one on the list there, and that's the abrupt discontinuation of therapeutically prescribed corticosteroids. Now, much is made of the pigmentary cutaneous changes seen in Addison's disease. Either the vitiligo is shown here, or hyperpigmentation that's classically seen in the palmar creases, in scar tissue, and in the buccal mucosa and gingiva. It's only seen in primary adrenal insufficiency. It's due to high circulating levels of ACTH, which also has properties like melanocyte stimulating hormone and stimulates melanin production, although it's not all that common, actually. Here are some of the subjective symptoms of adrenal insufficiency. Except for this salt craving, most of these, if you look down the list, you'll see are quite nonspecific. Difficult to make this diagnosis just by having a couple of these findings. Same holds true pretty much in terms of the objective or physical findings. The one here that might be more specific are what I call pituitary signs. So that would be like the patient who has a secondary adrenal insufficiency from expanding pituitary mass and gets bitemporal hemianopsia. That has some specificity to it. But otherwise, you're going to really need a constellation of findings from the history, physical, and probably laboratory studies to be, as well as a high index of suspicion for making this diagnosis. Time for our thinking caps again. If we could bring up the next question. And the question is, which laboratory finding is typically seen in adrenal insufficiency? Please start the clock. Is it high sodium, low potassium, high BUN, high glucose, or is it low calcium in the blood? And our answer is well, by democracy it's number 2, but by Cruz it's number 3. So let me show you the list here. Again, these are pretty much non-specific findings, but here's the list of what occurs classically in adrenal insufficiency. It's actually not hypokalemia, it's hyperkalemia. The azotemia, from reading the sports page there, that anabolic steroids, those are the kind of androgens, can cause increased anabolism, but the glucocorticoids tend to cause catabolism, and that means that you're tearing down proteins and your BUN goes up for that reason, and even more importantly goes up because without aldosterone produced by the adrenal gland, you tend to get prerenal azotemia from the volume contraction. So sometimes these are helpful, particularly when the patient first presents. Once they're in the ICU for a while, then, we're pretty much responsible for these, and anything kind of goes, or else we've fixed them and they're no longer present. The definitive test in the ICU setting here is the rapid co-syntropin test. The idea is to draw a baseline cortisol level, give 250 micrograms of this synthetic version of ACTH called co-syntropin, and then repeat the cortisol assay 30 and 60 minutes later. Now, if your patients are, you're really worried about this being the problem, you can go ahead and give the hydrocortisone treatment right after you draw the last specimen. You don't have to wait for the assays to come back. And if you're really worried, like they're in shock and you think it might be from adrenal failure, you can't go ahead and give the hydrocortisone before you draw any of these, because hydrocortisone and cortisol are the same molecule, so you'll really be doing drug levels in that case. But you can go ahead and give a dose of dexamethasone. That's the one steroid glucocorticoid we have on your formulary that won't cross-react with the cortisol assay. Methylprednisolone, prednisone, they all cross-react at least to some extent. So you can give dexamethasone up front, one dose, draw the last test, and then change over to hydrocortisone. Here's some real data from the literature. This isn't a co-syntropin test. It's a real ACTH test, which pretty much isn't done anymore, but it has the same results. So here's a group of normals, and you can see that they doubled their cortisol level. That either happens at around 30 minutes or around 60 minutes, so that's the reason for getting 2 tests there, so you don't miss the peak. And now we have 2 groups, patients superimposed. One group has chronic adrenal insufficiency, and you can see they have a flat profile, hardly any change once they're stimulated with ACTH. And up in green, we have a group of patients with severe sepsis. They have high baseline levels, but as you can see, a relatively flat response, implying that although they're producing cortisol, they can't produce more, so they're at their limit, and who knows if that limit is enough to meet the demands of the system under this stress. So that's what has caused all the concern about whether steroids might be necessary in some groups, subsets of patients with severe sepsis. And I think Dr. Pearl will probably touch on that a little bit later. The treatment for classic adrenal crisis then is to replace the hormone using IV hydrocortisone. How much? Well, the most the human body can make under the most stressful conditions, if you've got good adrenal function, is maybe 200 or 300 milligrams in a 24-hour period. So that's the dose. It's not called a pharmacologic dose, but a kind of a physiologic dose for the stress. So 200-300 milligrams given in divided doses over the 24 hours. That would be given each day. Equally important is the volume expansion, because if they're not making aldosterone, then they're going to be volume contracted, and that can cause the adrenal shock and hypotension. You don't need to give fludrocortisone if you're giving doses of 100 or 200 or 300 milligrams per day of hydrocortisone. At those doses, it'll have enough intrinsic mineralocorticoid effect. But once you wean it down to less than, say, 100 or so milligrams per day, then if your patient has persistent adrenal failure anyway, they're going to need some of this synthetic version of aldosterone in terms of replacement. The fluid of choice is D5 normal saline. The D5 part is because they're prone to hypoglycemia, and the normal saline part is because they need volume expansion, and isotonic fluids do that better than hypotonic fluids. And remember to monitor electrolytes. We're in the home stretch here with diabetes insipidus. It comes in two flavors, central or neurogenic, and then the nephrogenic variety. This is caused by an absolute lack of the antidiuretic hormone vasopressin. And here we have plenty of vasopressin circulating, but the distal nephron is simply refractory to its action, cannot elaborate a concentrated urine, and the result is polyuria and loss of fluid from the body. Let's see how we measure up with our last question here. Which urine osmolality is most consistent with complete central DI? Please start the clock. Is it less than 300 milliosmoles per kilogram water? 300 to 800? 800 to 1,000, greater than 1,000, or does it depend on the salt intake? This is urine osmolality, remember? And the correct answer is less than 300. We did pretty well on that one. So this tells us that the patient has central diabetes insipidus. Now, if your patient is hypernatremic, this is all you really need to do to diagnose DI, is just measure urine osmolality. The problem is that in ambulatory patients, they don't get hypernatremic. They make sure they're always close to water, because they're always thirsty and they're always drinking, and they prevent this from happening. Thirst is a very powerful motivator. In the ICU setting, however, by the time you're thinking of this, most patients have a sodium that's either at, close to, or even well above the upper limit of normal. In that case, all you need to do is check the urine osmolality, and if it's less than 300, you've got your diagnosis. It becomes a little more complicated if the patient has underlying renal problems or if they've been given diuretics recently, but otherwise that tells you the diagnosis. Then what you need to know is whether it's central or nephrogenic, and you can differentiate that by simply repeating the urine osmolality after you give them some antidiuretic hormone, and usually today we give the synthetic version of that called DDAVP. If there's no change, then that's what you expect with nephrogenic DI, and if they have a complete central DI, there will be a striking change, at least and usually well over a 50% increase in urine osmolality. The treatment here is fluid replacement. These patients can lose as much as 20 or 25 liters of urine output a day. And once you're losing a liter of urine an hour, it doesn't take long to get very dehydrated, and you can even get hypovolemic, even though that's essentially all free water. So you have to keep up with their fluids, and if it's a central DI, once they get more than 5, 6, 7 liters of urine output a day, it's hard to do that, and there's no point in trying. You just give them some replacement hormone, and that's in the form of vasopressin. If it's nephrogenic DI, stop the causative drugs. That's the usual reason they have it, and the only pharmacotreatment that you have available is thiazide diuretics, which paradoxically can help decrease the urine output in nephrogenic DI. Here are some forms of vasopressin. This is pretty much defunct. The tannate in oil used to be given chronically. This is sort of the former criterion standard, and nowadays we use desmopressin. The reason is this affects not only the V2 receptors at the level of the distal nephron, but it affects the V1 receptors in our systemic arterioles, causing vasoconstriction and some of the complications like precipitating acute coronary syndrome in susceptible patients. If you give desmopressin, it's a pure selective V2 agonist and avoids that and works just as well. And it's also the chronic treatment can be given conveniently to ambulatory patients by the nasal route. Last thing I'll touch on here briefly is pheochromocytoma. It's a neuroendocrine disorder consisting of chromaffin tissue, and it follows the rule of tens. 10% are malignant, 10% are familial, 10% are bilateral in the body, 10% occur at multiple tumor locations, and 10% occur outside the adrenal medulla. Some of those can be outside the adrenal gland period, anywhere in the body, but most tend to hover down around the organ of Zuckerkandl. Now, here are the manifestations. The most common here are patients who get paroxysms that last 20, 30 minutes and consist of headache, diaphoresis, palpitations, and cutaneous flushing. But any of these symptoms can occur, and they're always in conjunction with hypertension. Well, I won't say always, because there are rare cases where patients can actually get hypotensive with the episodes. And then there's the patients that have sustained hypertension as well. This is an uncommon syndrome. It's 1 out of 1,000 cases of hypertension. So you don't see it very often at all, but the culprit here is production of these catecholamines by the chromaffin tissue in an unregulated fashion that produces these surges of release of catecholamines and causing the symptoms. We can measure these in the plasma or in a 24-hour urine, and that's one way to confirm the diagnosis biochemically, or we can also make measurements of their inactive metabolites, VMA here, or these two so-called metanephrines. Now, here's a list of various biochemical confirmatory tests. The classic is the 24-hour urine for metanephrines and VMA. This chromogranin isn't widely available but may have some advantages. The provocative tests, trying to give histamine injections and see if you can bring on hypertension, are obsolete and quite dangerous, as is the IVC sampling. But probably the most useful test here today in patients who have a high suspicion of this are the plasma metanephrines, not the urine, but the plasma metanephrines. So there have been a number of studies recently. Here's one of them, a group of patients in yellow with pheochromocytoma, and if you can see the faint purple line there is the upper normal limit. Good separation there if you measure both of these metanephrines here, and for comparison groups, they have patients with other forms of hypertension and cardiovascular disease, and pretty much you can use this to exclude the diagnosis. Once you confirm the diagnosis biochemically, the next step is to localize it. And there's a long list of options here, but suffice it to say that the vast majority of the time that's going to be done by either CT or MRI. MRI is particularly useful because it turns out that the T2 weighted spin resonance mode really lights this chromaffin tissue up brightly and helps to find them even when they're, especially when they're outside the adrenal gland. The first treatment is when the patient comes to the ICU with their hypertensive crisis. That's where you're likely to encounter them. And the treatment of choice there is the non-selective alpha adrenergic blocking agent phentolamine that can be given by continuous IV infusion and titrated to effect. You can also use nitroprusside. Phenoxybenzamine is kind of an oral version of phentolamine and can be used chronically once you get them weaned off the IV version. Beta blockers can be used as adjunctive therapy, but you never ever want to use beta blockers alone in these patients because the unopposed alpha stimulation can either precipitate or worsen their hypertensive crisis. There's some other options shown here, but the definitive treatment is surgery. 3/4 of the time you can cure these patients by removing the tumor. This is high-risk surgery, so you're likely to see the patient again. It's not going to happen on their admission for hypertensive crisis. They're going to leave the unit. They're going to go home. They're going to be well alpha-blocked and beta-blocked as an outpatient, and then once they're optimized, they're going to be admitted for this high-risk surgery. And I want to finish with this last slide here. This is an actual case from a publication. I think it was published in Hospital Practice. You can see this is a patient who preoperatively had very high levels of catecholamine production and postoperatively well within the upper normal limit there, so it was successful surgery. The interesting thing about this case report is they not only measured the catecholamine levels in the patient, but they also measured them in the surgeon. So here's the surgeon during routine surgery, kind of bordering there on abnormal, and here's the surgeon during this high-risk pheochromocytoma surgery. Seems to be a little nervous. Here's the resident. He's even more nervous. And the anesthesiologist, I guess, is kind of laid back and handles that pretty well. So with that, I thank you.